Good day, I am Sherilyn Francis with the National Center for Primary Care. We welcome you to part 3 of our Readiness for Adherence webinar series. We invite you to connect with us via social media at PriCare Matters and at our website, www.primarycarematters.org. Today's webinar is brought to you by a partnership between the National Center for Primary Care at the Morehouse School of Medicine and Novo Nordisk. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in underserved areas. The core principles of the NCPC are access, effectiveness, and equity. And now a few housekeeping measures. As participants, your microphones are muted and shall remain muted through the duration of the presentation. We ask that you check your internet connection for optimal video and audio experience. We ask that you refer all tech issues to the chat pod, and we ask that you refer all presenter questions to the question pod. There will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for discussion, question, and answer. The objectives for today's webinar are to describe the benefits of prescribing insulin and other injectable medications to address poor outcomes associated with medication non-adherence, and to compare and contrast insulin-based injectable combination therapies as a solution for medication non-adherence and their benefits and barriers for minority patients with diabetes. I now present to you today's webinar entitled Addressing Poor Outcomes Through Medication Adherence, Insulin and Other Injectables, moderated by Ms. Sabrina Jackson and presented by Dr. Sarah Reese. In compliance with ACCME guidelines, the following presenters have no financial or other relationship with manufacturers of any commercial service discussed in this educational activity. And now, Ms. Jackson.
So I have the pleasure of introducing today's speaker, Dr. Sarah Mandy Reese. Dr. Reese is a 2001 graduate of Mercer University College of Pharmacy here in Georgia. She is a certified diabetes educator and is board certified in advanced diabetes management. She is associate professor and vice chair in the Department of Pharmacy Practice at the Philadelphia College of Osteopathic Medicine, Georgia's campus, School of Pharmacy. Her area of clinical expertise and scholarly expertise is diabetes, particularly with a focus of gestational diabetes and insulin pump therapy. She, on a routine basis, provides diabetes education and management services for the Hall County County Health Department and the Longstreet Clinic. She's a certified product trainer for Medtronic and was recently elected to the board of directors for AADE for the 2016-2019 time period. Additionally, she was appointed by Governor Nathan Deal to the Georgia Commission on Medical Cannabis in May 2015. So, ladies and gentlemen, please help me give a very warm welcome to today's speaker, Dr. Sarah Mandy Reese. And Mandy, if you want to go ahead and just say hello, and then we'll get started with our question and answers. But I want to give you a little bit of time to get acclimated to our audience. So,
okay, excellent. It's my pleasure to be able to have a conversation with you all today. And I know that we all very much care about the patients that we work with and that have diabetes. And I hope today to have a conversation with you all and for you guys to ask questions along the way. Because we all have the same passion here, and that's caring for patients with diabetes. And your time is very much appreciated today, and your participation.
So to get our conversation started and kick things off, I do have a question. What makes medication non-adherence or adherence so complex?
Well, patients are complete people. They're not just, patients with diabetes. They have complex lives. We have to consider their social aspect of their life. What sort of family or support structure do they have in place? Do they live alone? Their financial, where they are financially, do they have health insurance and that sort of thing, and then other comorbidities. So as it is a patient that also has depression or anxiety, which creates a whole nother sort of layer of caring for that patient with diabetes. So we really have to look at, you know, not just whether they're taking their medication or not, but how is that patient doing as a whole, and really considering all of those factors whenever we're, you know, either prescribing or we're talking to patients about medication adherence. And when we talk in terms of medication adherence, we sort of create two buckets. So there's unintentional and intentional medication non-adherence. So unintentional is the patient's not planning necessarily to do it. Maybe they have cognitive dysfunction. Maybe there's a health belief there that they're really not comfortable taking the medications. And then we think in terms of, well, how do we work with these patients who have this unintentional adherence? And so really looking in terms of really keeping the dosing for insulin and other non-insulin injectables as simple as possible. So can we get the dosing down to once a day? With our new GLP-1 receptor agonist, we can do once weekly. And then the use of reminder systems. Quite often with patients during visits, we'll pull out the cell phone and we'll set reminders to take the medication. And really, you know, discussing with the patient, you know, why they need the medication, why is it important, why is it relevant, and for them.
So that sort of addresses the unintentional. Then yes, my next question is, what about the intentional?
So for that patient that is, you know, intentionally looking in terms of they're not taking their medication, motivational interviewing is an excellent tool in our toolbox that we can use to really have a dialogue with the patient to better understand them, because we have to first seek to understand that patient, because then that patient knows that we care, and then they're going to be willing to listen to input that we would like to share with them. So in terms of motivational interviewing, we're facilitating, we're engaging that patient to look at what is their intrinsic motivation for, you know, taking their medication or changing a lifestyle behavior in diabetes. But it's all about being patient-centered. I had a patient actually the other week I saw in clinic who was not taking her mealtime insulin, and so started doing some motivational interviewing with her. And as it turns out, she was not wanting to take her insulin or too much of it because she had read on the internet that the insulin would hurt her kidneys. And so we have to, in motivational interviewing and also asking patients questions, not making assumptions about how a patient takes their medication. So never assume just because we have it in our electronic medical record or in our pharmacy profile that a patient is taking it, much less how they're taking it. So with each patient encounter, asking the patient, what medications are you taking? How often are you taking those medications?
And Mandy, if I may just interrupt you for a moment, I am participating in an expert panel with another project around looking at previous education programs that some people have done around the country. And in reviewing, preparing for this experts panel, there was a story about a tool that someone used to motivate a patient to come to class. And it basically centered around the fact that the nurse saw the patient in clinic who had been missing appointments, and asked her to write out her will and to go ahead and plan her funeral service, because her diabetes was so bad that her death was pretty much imminent. Now, in this case, it worked. The woman came to class and she completed her DSME. But I just wondered if you wanted to weigh in a little bit about those kinds of I would call them scare tactics, and just maybe the impact that that can have on some patients.
It's patient specific. I would say in general, it's probably not a good idea to use scare tactics, because then a patient's acting out of fear rather than an internal motivation to participate in their health care by taking their medications. And it's, you know, yeah, it's okay to talk about possible complications, but I would wait until after really having the patient share their story and what motivates them. What's that internal driver? I would not start with scare tactics, and I would use those in moderation.
Mhm. Gotcha. So let's talk a little bit about, we're sort of on the idea of outcomes now. I'm not sure if that is your next slide, but what are some underlying barriers that clients, particularly minority clients, face? And then what kinds of poor outcomes are patients looking at when they're non-adherent or when they're having adherence issues?
Sure. And on the next slide here.
So either it's going too fast or it's going too slow, huh? Here we are.
There we are. So these are some general barriers that we see, with patients, and you can see there's treatment specific, patient specific, and I want to go ahead and actually, let me just highlight 3 quick things on here, and then we'll move to the minority patients. But in terms of in terms of patients remembering to take their medication, that's where cognitive dysfunction, whether it's a vascular dementia or truly an Alzheimer's type of dementia, really plays an important role in those patients. And so really that's an important factor to consider, because if a patient has some memory loss, it's going to create an unintentional medication and non-adherence. And then looking at terms of the patient's skills and knowledge. So do we give the patient, a printout with information on it and that patient can't read? And, when we give a patient a vial of insulin or an insulin pen, has that patient been educated on how to use that or gain that skill and how to use that particular product? And we'll talk about cost a little bit more detail in just a few slides. I actually have a poll question at this point. If everyone would kindly participate and answer from your perspective, what would you pick as your answer? Excellent. So the majority of folks picked unique cultural beliefs, yes. And so while all of these would are technically barriers to medication non-adherence for minorities, because we know access to care can be an issue, and in terms of health status. What I actually had in mind when I was developing the slides was really looking in terms of unique cultural beliefs. And just based on experience that I've had and worked with students who are from Asian countries, and the health belief of natural products. So use natural products, not necessarily medications. I remember a student telling me his mom needed to be on insulin, and she just really wasn't willing to take that because her cultural belief was that she would take a natural product. Recently, having actually over the last 9 years working with gestational patients who are primarily Latino, the belief that these women have shared with me is that their belief is that insulin will actually harm them and actually kill their baby. And so it really took me just sitting back, listening, and then dispelling those myths. And you can't necessarily put everybody that's maybe Latino or everybody that's Asian in one particular bucket. Ultimately, bottom line, when we look in terms of poor outcomes, it comes down to A1C, because we know if the A1C is not controlled, there's numerous long-term complications that can occur as a result of this. And with these complications comes poor quality of life, disability, inability to work, and then death. Sabrina, you were sharing earlier with the patient that was basically at death's doorstep because she was choosing to not self-manage her disease. And ultimately, these medications are great because they improve the A1C, therefore preventing many of these complications that are associated with non-adherence. And it looks like it's time for another poll question. If everyone would kindly participate and answer, and then we'll see what the majority of the group has chosen. Excellent. So I think I gave that one away. Yes, the primary benefit is lowering the A1C. Now, this poll question brings up, I think, an important point just to mention here, and that is in terms of we know that there could be weight gain associated with insulin, but it's important to point out that if we address the dietary component, if we address the patient's physical activity, we can counter to a large extent weight gain that's associated with insulin use. So that's definitely an important point to keep in mind. Alrighty, so just looking here in terms of keeping that hemoglobin A1C at goal, that's what we ultimately want to achieve. And we know the general A1C goal, according to the American Diabetes Association, is less than 7%. But it's very important to also bring up that now we're talking about individualization of that A1C goal. So if we have a patient that has a shorter, life expectancy, maybe we have an 80-year-old patient who has multiple chronic comorbidities, they're on they have chronic kidney disease and things like that, we're not going to be as stringent in that A1C goal. So we may shoot for an A1C goal somewhere between 7.5% and 8.5%. So it's no longer that in terms of that one bucket, put everybody in that particular bucket. At this point, I do want to mention that in the full slide deck, there are additional slides on some specifics in terms of individual insulin agents as well as individual non-insulin injectable agents.
And that was going to be my next question is, in the comparison of the insulin injectables and non-insulin injectables, how do they differ in terms of cost and duration, dosing frequency? Because one of the things that we look at when we're looking at healthcare disparities, not just for minorities, but other ethnicities may have issues with access to care. You may have literacy issues that are causing some disparities. How do we account for that when you're looking at now some of these non-insulin injectables and having access to them?
Okay, very relevant question and pertinent. But when we think in terms of cost, and that's an issue for patients, because you think cost is to a certain extent can be a barrier to access. So when we think about these medications in terms of the insulin, a lot of times we use the older insulins, whether it's the regular insulin and the NPH insulin for a patient requiring mealtime and background insulin. That is an option that can make it affordable for a patient. There are a good number of patient assistance programs out there through the pharmaceutical companies that providers and their staff members can get help to help get patients enrolled in these programs so that the patients could have access to the newer technologies, whether it's our analog insulins that are rapid acting or long-acting basal insulins, so those patients can actually have access to it. Because it's almost as if you're in a catch-22 in one sense with your non-analog insulin, so your short-acting, your NPH, because while, yes, it gives a patient access, which is good, it makes it more affordable, there's also a greater risk of hypoglycemia or low blood sugar. And so that's a challenge when you have an elderly patient and they have a low blood sugar and then they fall over and they break a hip. Well, then you're looking at additional healthcare dollars and expenses. And so if we can get patients access through the assistance programs to these analog insulins, that is very, very beneficial, and being aggressive in applying for those programs is very helpful. And then also with our newer agents that are on the market, our GLP-1 receptor agonists, and most recently in November, our newer GLP-1 receptor agonist basal insulin combinations, which you think in terms of, man, that's once a day dosing with this combination. And so it gives us, in terms of adherence, less frequent less doses, less frequent, which is going to increase adherence. And so,
question. Well, a few things. I don't know if everyone in the audience attended the talk last time when we had Dr. Holloway, but one of the things that he talked about, and I know for me as an African American, you know, some of the, I'll say cultural beliefs, because I won't just say myths, I'll say cultural beliefs, is this fear of, you know, newer medications and whether or not some communities can trust the evidence. And so one of the things that Dr. Holloway did bring out is that for some of the, and I can't remember exactly the medication that he mentioned, but he quoted a couple of trials that noted that most of the studies did include minorities. And so they know that the research shows that they can be effective in our communities. And that's one thing that I wanted to point out that we need to help to get across to our clients so that we deal with some of the fear that's not, is not necessarily imagined because we know the history of some things that's happened in the healthcare system, but to help give them the right information, but also in helping our providers who are out there, who some of them may be working in FQHCs or they're working in underserved areas. And we all know that underserved translates into understaffed, underfunded, undertimed. And so just like our patients lack resources, us as providers, we lack resources in terms of staff and time. And so I'm just wondering, as a pharmacist, if you had some practical solutions when we start to look at the patient assistance program. Some people in our audience may be in rural areas and you don't get many visits from drug reps. And so there are things that you may not know or you may not be aware of. So any suggestions on how to get the information on the pharmacy assistance programs and who on the staff should handle that? You know, should we point to one person? Should we take a day of the week to do it? Any suggestions on that?
sure. I mean, that's a very good question. One, the first thing that pops into my mind is collaborations. Maybe there is a local college of pharmacy or school of pharmacy that's, you know, within 2 hours. Oftentimes these schools are looking for sites to have their students go and learn. And so utilizing the schools of pharmacy, colleges of pharmacy, even medical schools to collaborate and have them help with developing resources and tools with how-to sheets and information and education for the patient. And then it's really kind of up to the clinic. What I would do, what comes to mind is to really almost have a champion within the office, a point person. Maybe it's a medical assistant, it's a clerk, you know, or maybe I would say the nurse is usually busy with the physician and that type of thing, or PA, nurse practitioner, but maybe having a clerk that is a champion for this, that gets to know the system in terms of what's the process for the drug assistance program, what paperwork's required, and really getting that, really charging that person with doing that. Or if you could bring in a health educator into the practice, and that's another great opportunity, or community health worker. Those are great folks to have join the team, get them integrated, and create that champion for patient assistance in the practice.
Okay, thank you. Helpful suggestions. You may continue.
Okay, thanks. All righty. At this point, it looks like we have, I want to go to a poll question. It's poll question number 4. And so if everyone would participate, and then we will take a look at our results. Excellent. So yes, so it's the basal long-acting insulin. Yes. And again, you know, just to emphasize kind of what we've already been talking about, is that, you know, access to some of these insulins can be a challenge. And so we have to really keep that in mind. And again, having that advocate within the practice or the clinic that can assist with the patient assistance program. I know here I live in Gainesville, Georgia, and there is a indigent clinic called the Good News Clinic, and they actually have a volunteer that comes in, and that's what she does, is she oversees the patient assistance program. And so just wanted to highlight that. So looking at this slide, and this is from ACE, so this is from the endocrinology group, you look in terms of where does, insulin, where do our non-insulin injectables really fit into the treatment of type 2, kind of looking here. Now keeping in mind, the endocrinologists typically sort of have a, tighter goals and that type of thing. So if you look at the slide here, now GLP-1 or incretin mimetics can actually be used as initial therapy in diabetes. Now, we'll say from the standpoint of compliance, these can be given once a week. And so that actually can take away that barrier of non-adherence from that standpoint. For the patients that's not controlled on monotherapy and you're starting to look at dual therapy, and then further down the road you're looking at triple therapy if the A1C continues. So then you start to incorporate your basal insulins, typically is first insulin in type 2 diabetes that is actually usually included. But I did want to bring out an important point here. It's not a topic for today's webinar, but that metformin is still considered the cornerstone of therapy for type 2 diabetes, just to mention. I think that's an inexpensive medication. You can get it for $4. And so that is an excellent medication. We are ready for our next poll question. So poll question number 5. If everyone would kindly answer this question and let us know what you would pick, and then we'll see what the group thinks. Okay, excellent. So the majority of the group did choose the GLP-1 receptor agonist. Yes, and so that is a alternative to prandial insulin, and we've not really always had that. That's a newer option that we have. So looking in terms of intensity or intensifying glycemic control, so maybe that basal or background insulin's not enough for the patient. So looking in terms of what are other options that we can move to outside of just the basal insulin. And so we see here, now keeping in mind what I had mentioned before, your GLP-1 receptor agonists are an option as an alternative to basal insulin. So maybe a patient does have a fear of insulin that's they're not willing to take it. Using a GLP-1 receptor agonist would be appropriate in that scenario. But looking here, the big takeaway from this is no longer is it one size fits all. So when you're dialoguing with the client, with the patient, looking in terms of their mealtime, blood sugars aren't well controlled, what can you do? So we have other options besides just prandial insulin now, and you can see those here on the slide. Now this particular webinar is not going to go into the DPP-4s and the SGLT2 inhibitors, but those are additional options. Now, I want to mention just a couple of advantages in terms of our GLP-1 receptor agonist. They do provide the advantage of weight loss and a lower risk of low blood sugar. So for patients, that can be quite significant. I'll start talking while we're in the process of getting to the solution to medication non-adherence, but really customizing, really having a dialogue with the patient is absolutely essential. Listening to the patient, what are their financial challenges? So maybe they do have insurance, but what is the deductible? Can they afford that? What drugs are preferred? Also their cognitive ability. Do they have dementia? Not just Alzheimer's, but any type of vascular dementia. What's their current lifestyle? Are they still working? Are they retired? What's their work schedule? So if they are still working full-time, are they working day shift? Are they working night shift? Are they working, what shift are they working? And then also their medication beliefs, to really find out what they truly believe, and creating that non-judgment non-judgmental environment so that the patient feels open to share that. Because the worst thing we could do is see a client, see a patient, make a therapeutic decision, and then the patient goes home and says, you know what, I'm not gonna take that. And so again, we talked a little bit about the cost of it in terms of insurance. So again, many patients in minority communities do, have access challenges. And so we had already talked a little bit about the patient assistance programs. In terms of, also in terms of solutions to medication non-adherence, really looking in terms, what does that patient believe about medication, and taking time to really listen to what the patient's telling us before we start cutting them off and going, you know what, you're wrong and this is what's right. We don't want to do that, but we want to listen to the patient and then be able to dispel those beliefs. Now, in terms of lifestyle, for that patient, depending on what, period of life that they're currently in, in terms of what is their work life like, their family, we really want to create the least complex medication regimen possible so it doesn't interfere with the patient's quality of life. So poll question number 6. And if everyone would let us know, what are your thoughts? What would you choose for a patient that has cognitive dysfunction as a possible solution? Excellent. So that once weekly GLP-1 receptor agonist. Yes. So if we continue our look in terms of solutions for medication non-adherence, in terms of really discussing with the patient, what do they know about this medication, and then educating them in terms of how do you use that. So how do you use an insulin pen? How do you use a vial of insulin? And using the teach back method. So show the patient how to do it and then have the patient do it before they leave. In terms of cognitive dysfunctions, there's numerous tools out there in terms of screening. You could do the mini mental status exam is one option of utilizing to see what is that patient's, cognitive ability, and ultimately really simplifying it for that patient. So these are some solutions. What benefits can we get from these insulins and non-insulin injectables? So in terms of insulin, you just really have to think of it because there's so many sort of different insulins, whether we think of it as, mealtime or bolus insulin, whether we think of it as generic insulins or our newer analog insulins and those types of things. Now, Sabrina brought up a good point earlier about cost, and sometimes cost being a challenge. And so using the generic insulins, the Humulin R, the Novolin R, the NPH, really decreases the barrier for access to care, simplifying the regimen as much as possible. Keep them in mind, typically for type 2 diabetes, we typically start with a basal insulin and really trying, if at all possible, for patients, at least when we're starting in terms of insulin, really keeping it once per day if possible, because ultimately our ultimate benefit is lowering the A1C so we prevent the complications. Our newer drug class, the GLP-1 receptor agonist. Now these have some clear benefits, but again, there's some barriers here with this particular drug class. Again, lower risk of having low blood sugars, that less frequent dosing that's not going to interfere with the lifestyle of the patient. But again, costs can be a barrier. So what you will notice when we talk about in terms of insulin and we talk in terms of some of these non-insulin injectables, there are very clear benefits and barriers for both of those particular buckets. Looking at the newer agents that are out on the market since about November, December, their approval in terms of the combination of your basal insulin and your GLP-1. you know, from an adherence standpoint, it's great because it's less frequent dosing. It's not going to interfere with the patient's lifestyle. If the patient has cognitive impairment, you know, it's not a complex regimen. But again, cost can be a challenge here, and that's where that patient assistance program does come into play.
And Mandy, do we have a concern with the pharmacy assistance program with a time limit? So we get a patient on it, they're stable, but they can only stay on the program for a year or 2 years.
That's okay. So, you know, the patient assistance programs are great, but quite often it's that reapplying every year to get the medication. So I think whenever folks are thinking about staffing in their clinic or in their office, you have to think about the fact if you get all these folks on patient assistance, which is great, but you're going to have to help them reapply the next year. So account for that time commitment when you're thinking about your manpower and that type of thing.
And also letting the patient know that that is the expectation. That
Yes.
Once a year that they have to reapply.
Yes. Let the patient know that up front. All right. So let's move to some of the barriers. And I think we've mentioned some of these already in terms of cost, you know, and that just seems to be such a prevalent topic today in healthcare is cost. And so it's even for the patients, and I want to mention this again because it's very important, it's even for that patient that has health insurance, we need to know, keep in mind, can they afford the copays? How much are the copays? Have they met their deductibles? So we have to keep that in mind as well. So quite often, if we have areas with limited access minority communities, that patient may be on Medicare and Medicaid, and so what's going to actually be covered, it's important. And a lot of times some of these newer products are not included. Now for the patient that's requiring, maybe we have a patient that's a self-pay, that they're going to be using some of the older insulins, adherence from a frequency in terms of how often they have to take the medications is going to be a challenge, and really discussing that with the patient, writing down clear instructions, having the patient repeat back, utilizing reminder systems, even check boxes on a piece of paper so the patient can check off when they've taken their medications.
And if the audience has any questions now, it's a great time to go ahead and submit them to us.
And this is, the next point is actually a very important point, and that's in terms of side effects. So if a patient's going to start specifically on insulin, because we know that risk of low blood sugar, make sure that the patient knows what low blood sugar is, what does it feel like, and how do they need to treat it. Because the worst thing possible is for a patient to start on insulin, not know what it's going to feel like, and suddenly they get dizzy. You know, maybe they take their Humulin R right before they eat lunch, but then they get a phone call and they're not able to eat, and then they pass out. That's going to scare the patient to death. They're probably not going to take it again. So that education is absolutely essential. And then also teaching the patient how to inject and watching the patient do that. And that's sort of the end of the slides that we have for you. Would love to have some questions from the audience, and let's have some conversation and that type of thing.
All right. Sherilyn, are you able to pull up the Excel spreadsheet to take some of the questions from that? And while you are pulling that up, Mandy, I did have a question, and it goes back to the motivational interviewing. And I just wondered if you could weigh in a little bit on providers actually having that skill. I know for some people there is you may have a community health worker or a health coach, or the nurse manager does that. I wanted to see what you thought about the weight of having the provider be a part of that conversation, and yeah, just what you thought about who should be involved in helping the patients to adhere to the medication.
Sure. I think the whether it's whoever's doing the visit, the exam and that type of thing, whether it's the physician, nurse practitioner, PA, that's in with the patient, I think they can start that process with the patient and really sort of. It's not going to be extended because the time is so limited to get to do that patient visit, but to start the process and to allow that patient to open up and share and get their thoughts, and then allow, if they have a diabetes educator, community health worker, health educator, pass the ball off to them to continue that conversation with the patient. And whatever type of charting that's done, whether it's in the EMR or if it's, done paper charts, to report back and make notes of, what information was gathered through that process.
Gotcha. Thank you. I don't know if there are any
Yes, we do have a few
questions
questions.
coming through. Okay.
Okay, wonderful. So first question, would the use of video on a mobile app, essentially mHealth interventions on patient education, would that be useful to reduce or actually increase medication adherence?
I think if the patient is open to it, depending on the patient population, you have to keep that in mind. Now, some older patients might not be very trusting of it. So if the patient is open to it, I would say yes, definitely, because you hear a lot about utilizing technology and that type of thing to communicate with patients in rural areas, to do education where there's not physically an educator in the area. So yes, I would say that's a great resource and tool, assuming that the patient is trusting of that. And so that's a question that really needs to be asked before that tool is put into use, because the worst thing would be to try to do that, the video type of tool with the patient, and then the patient feel like, oh my gosh, is the government looking at me? Who's watching this? Who's listening?
Mm-hmm. And Sherilyn, I do have the list up now, so thank you. I thought this was a really good question for you, Mandy, just in terms of your professional role every day. What criteria do you look for to assess readiness or appropriateness for insulin pump usage?
I would say there's sort of several points to that. One, depending on the insurance, I know Medicare requires this, you have to measure the C-peptide level. So that's actually very important. But also looking at that patient, so they have to be doing bolus insulin for each meal and a basal insulin, and they have to prove that they are compliant or adherent. So they actually are taking their insulin before meals and at bedtime, and then also that they're checking their blood sugar, because quite often many insurance companies will require 30 days of blood sugar values before they will actually cover the insulin pumps. So that is an important point to keep in mind. Medicare is good about covering insulin pumps, not just in type 1, but also in type 2 patients. So insurance coverage, what is that patient's insurance? But big points is compliance with the current insulin regimen, and then also that their willingness to check their blood sugar. A couple of other points is maybe the patient's experiencing hypoglycemia unawareness, or the patient has erratic blood sugars. So the insulin pump can actually help in both of those scenarios.
But with the scenario where you're having the erratic blood sugars, then you'd need to rule out that it's not an adherence issue.
Correct. Yeah. Yes.
And somehow demonstrate that.
Typically where you see really erratic blood sugars, for the most part, is typically with type 1. And that's just sort of the nature of the beast. With type 1, the blood sugars typically are more erratic. With type 2s, it's usually, for patients with type 2, it's usually a little bit easier to identify, is it the patient, they ate and then they took their insulin, their mealtime insulin, and they forgot to take it. Now they're chasing their blood sugar. So it's a little bit easier to identify patterns in the blood sugars with type 2s.
Mm-hmm. And here's another great question. How do you help a patient that is depressed with adherence issues?
You know, it's interesting. I actually saw a patient earlier this week in clinic who was depressed and had anxiety. And, you know, really talking with that patient about, you know, really trying to get at the core reason of why they want to manage their diabetes, what's their motivator, but also having the discussion that they've really got to get their depression under control. Quite often, if there is a psychiatric illness going on, whether it is bipolar, depression, anxiety, schizophrenia, if the underlying, you know, psychiatric illness is not well controlled, it's going to be difficult to control the diabetes.
And we know too that managing disparities, that we have to have a comprehensive approach for all chronic illnesses. But in terms of, you know, one of the best practices that's evidence-based is system redesign. And so we have to incorporate screenings for distress, particularly for patients with chronic disease. And that's where the diabetes distress scale can come in. But I know that for, again, a lot of clinicians, it just needs to be in the workflow in order to have it done. It needs to be defined, who's going to do it, and just become a part of your regimen, because during those screenings could actually illuminate problems that you don't really know exist. So let's say help to fuel conversations. So, and it makes having that talk a bit easier. So during the depression, during the diabetes distress screening, and we can make that available as well as definitely on the website, but we can send it out as part of the newsletter if anyone is interested in that as well. So.
And that's a great resource and tool, and it's important that every patient encounter that screening tool be used. And so, you know, whether it's the provider doing it, whether it's the nurse doing it, whether it's the educator doing it, at each encounter it has to be done, because it can change over time. There could be a certain trigger in that person's life that's going to create, you know, anxiety or depression that at the last office visit wasn't there.
And it can easily be incorporated into your EHR so that you have alerts that pop up to remind people to do it. So a really good best practice to implement. And I think we have time for one more. Let's see. There's someone here, and I'm assuming that they're alluding to maybe migrant populations, but how to deal with adherence for patients who, adherence and continuity of care for patients who move frequently.
Man, that's a tough one. And there's not an easy answer to that particular question. I know that there are vans. I'm originally from South Georgia, a very large agricultural community, lots of migrant population movement through there depending on the season and that type of thing. And I know in some of those areas they actually have vans that come out, mobile vans that will come and see patients in terms of that. But, you know, I would say a couple of thoughts. One is for that patient, you know, to discuss with them in that visit the importance of that diabetes is a lifelong disease, that you have to have ongoing care. So if you do move, you know, look for a clinic in the community where you're going to live, and quite often that population is not going to have, you know, health insurance. So talking about finding, you know, indigent clinics and, you know, maybe resources like that are available. And then also I would say making sure that that patient carries a list of their medications as well with them, so that when they, you know, maybe go to the next area to work, at least they have the list of their medications, so when they go to that clinic, you know, that they have that. So.
And if, I'm not sure who asked that question, but if you are referring to a migrant population, there is the Migrant Clinicians Network. It's MCN. I want to say it's mcn.org, but you can definitely Google it. And they have lots of resources, webinars about caring for migrant or transient populations that could be helpful. But another idea that I thought about is that what many of you may have seen in gynecology or in OBGYN is that passport to health. They're the little booklets. And so if any of you have never used it before, but it looks basically like a passport where the women, and it may have been done through the Department of Community Health, it may have been through WIC, I can't remember, but they were supposed to get stamps for every visit, but it's a good place for them to write down whatever their prenatal labs are, what their due dates are, whenever they had their last ultrasound. And so a clinic can create something like that. Just word to the wise, you should probably do it for every patient so that one patient doesn't feel singled out. But it's just a good way to do it. It helps your clients or your patients to know, sort of to own their health, and they're able to look and see when was their last A1C and what was that number, and when was the last time they saw the educator, and if they're going to class, those kinds of things. You can create one yourself, you know, just by using a sheet of paper or sort of a folder that you give, and that may be helpful, that every patient has and they take with them. One of the things that we do at our, you know, that one of the things that's known at our charity hospital, that patients who are Grady patients, they brown bag it. And so oftentimes if you're at the FQAC and you see a patient that comes in with a brown bag, you know they've interfaced with Grady, because it's something they teach all their patients, that every time you come to the doctor, you throw your medications in a brown bag and you bring it with you to every visit. And so, you know, you can sort of do those kinds of things that every patient knows that whenever you come, you bring your medication and you bring this booklet or you bring this paper with you. So I'm not sure if there are any, Sherilyn, I'm not able to see the chat box. I don't know.
We have a few more questions. So
Okay.
first question for either you or Dr. Reese. Can you please repeat the name of the pharmacy assistance program that you referenced earlier?
It's patient assistance. The website to actually go to is needymeds.org. And so it's NEEDY meds, MEDS.org. And that is sort of almost kind of like a clearinghouse, in that they have links to all of the
Yes.
patient assistance programs that are out there. So it's a fantastic tool to spread the word.
Yes, needymeds.org. It really helps them back in the day, looking in the PDF, the PDR, and then looking up the actual phone numbers for each pharmaceutical company, which is what I used to do. All right, Sherilyn, did you have another one?
Yes, so we have our final question. Can you comment on which therapies decrease cardiovascular disease?
Oh yeah, I'll be glad to. In terms of our GLP-1 receptor agonist, the one is liraglutide, that's been shown to decrease cardiovascular risk. Also metformin, and then an SGLT2, empagliflozin, has been shown to lower cardiovascular risk. Now, unfortunately, there's not any insulins that have actually been shown to lower cardiovascular risk.
Thank you very much. Those are actually all of our questions, and that is our time. Dr. Reese and Ms. Jackson, we thank you for an extremely informative and educational presentation. Additionally, we invite each participant and registrant, and you can tell your friends, to please save the date for part 4 of our 4-part webinar series. The date will be March 29th, and it will be a panel discussion where you'll have the opportunity to ask any burning questions that you may have about medication adherence, and to dialogue with a wide range of experts. Again, we thank you for attending part 3 of our 4-part series. You can connect with us via social media at Care Matters, and the webinar presentation is linked under handouts, but it will also be emailed to you along with the post evaluation, and you can also access the webinar recording and presentation at www.primarycarematters.org.
Thanks, everyone.
Thank you guys for your time.